Good morning, Dr. Lui and fellow friends. Today, me and Jay will present on assignment number 2 for clinical chemistry. So first of all, we would like to briefly explain about our case study. There's an 8-year-old boy admitted because of 5 days history, poor oral intake, vomiting and diarrhea. He was lethargic. Initial investigation was shown below. We are able to obtain the result for sodium, potassium, urea, creatinine, pH, PO2, PCO2, and HCO3. So for the question A, I will pass to Jay to explain about it.
The questions are to interpret the above investigation, which is 7 marks, and explain how the clinical scenario leads to the above blood gases results, which is allocated 5 marks. To answer question A, the boy was reported to have poor oral intake, vomiting and diarrhea, as well as lethargic. So the lab findings and the interpretation: sodium 128, which is decreased, supposed to be within 135 to 145, thus hyponatremia. For potassium 3.0, normal range 3.5 to 5.0, also decreased, hypokalemia. Urea 8.0, supposed to be within 3.5 to 6.6, increased, hyperuremia. pH 7.25, supposed to be within 7.35 to 7.45, decreased, acidosis. PCO2 4.5, supposed to be within 4.7 to 6.0, decreased. And lastly, HCO3 20, supposed to be within 24 to 29, also decreased. So, the boy is shown to have hyponatremia and hypokalemia due to excessive loss of electrolytes through vomiting and diarrhea, and causing hypovolemic. So, the lack of oral intake is also contributing to this factor as well. The hypovolemic condition is causing decrease in ECF, extracellular fluid, due to the loss of water, therefore leading to the stimulation of vasopressin release and causing renal water retention, which directly leading us to the next statement. So the urea creatinine test shows high level of urea. It determines dehydration due to lack of water. Thus, the kidney is trying to conserve the things that should be excreted. So you can see the urine output is decreased and the concentration is getting higher, leading to higher concentration to urea as well. As for the decreased pH, PCO2 and HCO3, it's known as metabolic acidosis.
For question number B, I would like to relate the clinical scenario to the blood gas result is we are primarily diagnosed the patient is having metabolic acidosis as it shown a reduction in HCO3, typically with compensatory reduction in PCO2. pH may be superly low or slightly abnormal. Because metabolic acidosis are categorized as high or normal anion gap based on the presence or absence of unmeasured anions in serum. The common causes are GI tract or renal HCO3 loss. So, which is this case, the patient is experiencing diarrhea and vomiting. The initial differentiation of metabolic acidosis should involve a determination of the anion gap. This is usually defined as the equation shown below. The equation value represents the difference between unmeasured cation and anion. Example, the presence of anion in the plasma that are not routinely measured.
That's all for our presentation. Thank you.